I have a few students, and it happens every year, I'm afraid, every exam, say, oh, I only got 4 wrong on multiple choice, but the computer or you gave me 6 wrong. I've got to take what you put on that bubble sheet, because that's what, that's what your final version of, or final answer is. Some people write down, circle the question sheet, and they might have them right there, but then they go and put them in wrong on the bubble sheet. The bubble sheet, that's the last, I can't tell if people have just changed their mind between circling the answer question sheet and filling in a bubble sheet, or, as it happened in the past, somebody has changed the question on the answer sheet when they realised what the right answer was, and said, hey, look, I circled A here, but I accidentally put B on the answer sheet. They changed the answer to A when they realised what the answer was. So you're responsible for translating. If you circle the ones on the question sheet differently than the bubble sheet, that's just tough. It's your job to fill in the bubble sheet correctly. Fair enough? Many people say, well, I don't understand how I got 7 wrong because I only got 4 wrong on this. But not every single time you go back and look at the bubble sheet, you circled whatever was 7 wrong. So I can't do anything about that. So just be careful when you go from your question sheet to your bubble sheet. The computer, the Scanton, doesn't make a mistake unless you answered, you gave 3 answers on the same question, something like that. You made a botch up on your actual paper, but that objectively grades what you put down. So sorry about that if you didn't put down what you meant to put down. Okay, I was a bit jumping all over the place last class on these receptors, I think. So this is, I prepared this summary. This is in your PowerPoint now. I deleted the old, whatever it is, lecture 4, and put this lecture 4 in, and that just happens to have this slide I just added in there. Okay? So this is basically all you need to know about each of those sensory receptors. The skin receptors, Merkel, dysmycin, proscenium, end-lobes, arousing, aphenius, corpuscle. So we went over all those last class, I think, but that is basically the summary, all you need to know about those receptors. And I don't think we'll come back to those again much. In your modalities class, your E-stim and your, paraffin baths, your hot packs, ice packs, these things are kind of useful for that. But in rehab, we won't use it much more in the neuro class, I don't think. Then we talked about the GTO, an very important receptor. This is the junction between the muscle and the tendon. The job of this thing, of course, is to sense force. Tell the brain, both consciously and non-consciously, how much force is being transmitted through that tendon by the muscle or whatever.
Ben, is that one slide the only difference between the lectures?
Yes, I think so, yeah. So if you want to go and print one slide again, that would be that slide, yeah. I think everything else is the same. Okay, so there's that GTO. And what it does, it's a summary, so it's a force monitor. It measures how much, or detects how much force is going to the tendon. And it's continually feeding that back up to the conscious brain, as it were, at the somatosensory cortex, of course, via what 2 pathways? What tracks take proprioceptive information to the brain? Gracilis, cystis cuneatus. Okay, depending on where the body, lumbar, sacral, cervical, thoracic. Cuneatus, lumbar, sacral is going to be gracilis, right? And they're going to end in the bottom of the medulla, in those nuclei, cross over, contralaterally now, they get ascending the medial meniscus up to the thalamus, and then the thalamus out to the brain. Okay, so that's how we feel how much force is in my muscle being generated by holding a weight, whatever. That's how I know. This information is also sent to the cerebellum, which we'll get to that late, in a week or so. that you have spinocerebellar tracts take proprioceptive information from the spine to the cerebellum, so the cerebellum knows what's going on in terms of force, in the tendons. So the other thing they do, the GTO, it inhibits the muscle it came from. Okay? Inhibits the muscle it came from. The high forces can actually turn that muscle off. That's called what? Autogenic inhibition. Okay? Autogenic inhibition. It's sometimes also called the inverse myotatic reflex. The inverse myotatic reflex. Okay? As opposed to the myotatic reflex we'll talk about in a minute is the muscle spindle. So the myotatic reflex is responsible for muscle spindle. The inverse myotatic reflex is this fellow, this Golgi tendon organ. An interesting last point about this before we go on muscle spindle. People have sort of theorized, there's a little bit of evidence for this, that the ability to oppose this GTO inhibition, overcome this, helps force production, helps in early strength gains. So in other words, if I was to go down to the gym now and start working out, doing a bench press, and let's pretend I can do 100 pounds on day one, how long does it take for me to actually lay muscle fibers down, myofilaments, to increase my muscles to allow me to do that bench press? How long does it take to hypertrophy a muscle? Yeah, you're very lucky now. About 6-8 weeks before you actually see physiological change in the muscle itself. In other words, myofilaments being laid down and you get hypertrophy. So according to that, you wouldn't get any change in the ability to do my 100-pound bench press for 6 weeks. Is that true though? If you work out 3 times a week, 4 times a week doing a bench press, do you think you'll get stronger? Do more than 100 pounds in 2 weeks? Heck yeah, a lot more force over 2, 3, 4, 5 weeks. You're producing way more of a bench press after 4 or 5 weeks of training, but there's no sign of hypertrophy in that muscle yet. So how on earth do you get stronger? It's neurological changes. It's motor learning, okay? You're recruiting the correct motor units in the right order. It's a skill. And one of the reasons why they think that you get those early strength gains before you get any hypertrophy of muscle is you can inhibit your GTOs. The GTOs want to turn your muscle off. In other words, they want to stop you producing force. But I want to produce more force. I want to get, lift this 250-pound barbell now. So this is sort of one of the ways that the central nervous system can modulate the GTO inhibition and allow you to produce more force. Okay? Alright. So that's the Golgi tendon organ. Found in the tendons. Do not confuse the GTO and its function with the muscle spindle. People do, unfortunately. Let's look at the muscle spindle now. This is unfortunately way more complex than a GTO. Every receptor we've talked about so far is purely sensory. It just has a receptor and it sends signals into the core. Right? The muscle spindle, though, has a motor component to it. Okay? There are little fusiform shapes. Fusiform means spindle. That's where it gets its term from. They look like that, basically. They look like miniature muscles, spindle-shaped muscles. Not muscles, spindle-shaped little capsules within the body of the biceps, the triceps, whatever. They're in the muscle itself. They lie within, alongside the biceps or the triceps, whatever muscle you're looking at. Okay? They lie parallel to them. Whereas the GTOs sit at the end of the muscle in series to the muscle. Okay? And as I said, they've both sensory and motor functions in there. They're quite a complex thingamajigs, about 2-3 millimeters long. Got lots of diagrams. What I'll do first, I think, we'll discuss the anatomy of it, what actually is there, the structure of this thing, then we'll talk about the function of it. And maybe the way to slow me down, I'll draw it, rather than just showing it on the diagram there. But perhaps, this is all you need to know, that diagram. Everything you need to know is on that diagram or that diagram. Okay. So, let's look at what makes up a muscle spindle, structurally wise, the anatomy of a muscle spindle. It's a little capsule-shaped thing within, there's hundreds and hundreds and hundreds of these within each muscle, okay? And within these muscle spindles, there are specialized muscle called intrafusal fibers. Intrafusal fibers. Specialized muscle fibers within the muscle spindle. The biceps, the normal muscle, as we referred to before, is called extrafusal. So my biceps is made of extrafusal fibers. Within my biceps, the little spindles, within those spindles are these intrafusal, fusiform spindle shape. Within the fusiform thingamajig, we have these specialized muscle fibers. Okay? Within the spindle, you'll find basically two, usually, I can't really draw these very well, but two bag fibers, which are kind of swollen in the middle. Two types of muscle fiber within there called bag fibers. Okay?
Did you have bag as in something
bag,
you could carry?
yes. Also called nuclear bag. The long term for that is called nuclear bag because, so they're represented by these two things in the middle here. These two. Because these muscle fibers are multinucleate. They've got more than one nucleus. And in bag fibers, in nuclear bag fibers, we find the nuclei in a bag in the center like this. Yes. Okay? So you've got a couple of those. One of those is known as the dynamic bag fiber. Dynamic bag. And the other one is the static bag. We'll get to what all these things do in a minute. So you've got a couple of these nuclear bag fibers, one static, one dynamic. And then alongside there you'll find some thin, I just put a couple, but there's usually about 4 or 5 of these, what are known as nuclear chain fibers. Thinner, not swollen in the middle. And they're represented by the right-hand sort of diagram on this thing here. Alright? On the right hand again. And they're called nuclear chain because the nuclei are arranged in a chain along the length of this fiber. Okay, so a couple of bag fibers, one static, one dynamic, and 4 or 5 chain fibers, roughly. Okay? The ends of these fibers we find that specialized skeletal muscle. So the actual muscle fiber lies at the ends of these fibers. Okay, so the muscles at the top and bottom of each of these fibers. In the middle, what's called the equatorial region, the equator, is non-contractile. There's no muscle fiber there. It's basically just, ligamentous, tendinous kind of material. So you've got the contractile portions at the end, and in the middle we have a non-contractile equatorial region. Alright, so far so good. non-contractile equatorial regions have sensory receptors on them. So the sensory receptors on those non-contractile middle bits. That's where the actual innervation occurs, the sensory portion of this. Okay? And there's two types of fibre arising from the muscle spindles, shown here. 1A and 2. Type 1A and type 2. Okay? The 1A fibre, I haven't shown this diagram here, but the 1A fibre has branches that go to every single type of intrafusal fibre. The 1A fibre has receptor terminals on all of them. Nuclear chain fibres. At the static bag, the dynamic bag, has a receptor on all of them. Okay? And that is usually called the annulospiral ending. Or primary endings. So the annulospiral or primary endings give rise to the 1A afferent, the 1A sensory neuron arising from these receptors. That gives rise to the 1A. Okay? The type 2 fibre afferent innervates all the fibres, all the intrafusal fibres except the dynamic bag. So the dynamic bag, you can see on this diagram here, is not innervated by the type 2 afferent. So that one on there is the far left-hand side, the dynamic nuclear bag. And that ending is called secondary endings or flower spray. It's called flower spray because it looks like a spray of flowers. Okay? I got it so far?
I have a question.
Yeah.
Type 1A and type 2, are these all coming out of the equatorial side?
Yes.
Okay.
All the receptor sites, the terminals, the endings of these neurons are on the equatorial region. Okay? Represented by this here, this here, this here. This bit here, all our afferents really. Close to the equatorial region anyway. Alright. Got it so far. So you've got a bag and a chain fibres, you've got a static bag and a dynamic bag, you've got these sensory receptors on these equatorial regions. The 1A fibre innervates all of the fibres. The type 2 innervates all of them except the dynamic bag fibre. Alright? Fair enough? So that's the sensory portion of this thingamajig. However, remember we have muscle fibres at the ends of these intrafusal fibres, and that is contractile. That can contract. So if it can contract, we have to have a motor neuron going to it. It can cause it to contract. Right? We have gamma motor neurons going to these fibers. And you can see on here, we have a static gamma motor neuron and a dynamic gamma motor neuron. As you'd expect, the dynamic gamma motor neuron goes to the dynamic bag fiber, which is the far left one on here. Can't see it. But here's the dynamic gamma motor neuron. It goes to the bag fiber. The rest of the fibers, the static bag and the chain fibers, have innervation from the static gamma motor neuron. Okay? So gamma motor neurons go to the muscle spindle. Where do alpha motor neurons go? Where are alpha motor neurons in this picture? What do? They go to my extrafusal fibers, of course, right? They go to the biceps that this is sitting in. Alright? See, alpha motor neurons go to your normal muscle. Your gamma motor neurons go to your intrafusal fibers. Alpha motor neurons go to extrafusal fibers. And we do have, we will probably get into this. No. We do have beta motor neurons. But they're remnants of the past and they get kind of very complicated. So we'll just forget about beta motor neurons for now. I think it's enough we know we've got gamma and alpha. Okay. What is all this mess for then? We've got a lot of complicated stuff going on in this muscle spindle. Well, their primary responsibility, of course, of muscle spindles is to detect stretch. That's their job, is to detect the length of the muscle. Not the force. The force is the GTO. They detect the length of the muscle. And if we look at, let's just stretch a muscle, and you see what happens to the 1A and type 2 afferents. So what I'm going to do, if I can find a pen that works, I'm going to stretch a muscle with a ramp stretch. In other words, I'm going to stretch from his hamstring perhaps. The line on the back, I'm going to hold it at this angle for a few seconds, and I'm going to ramp it up and hold it there. It's called a ramp stretch. I'm going to hold it here, and then ramp it up and hold it there. So this would be the stretch, length of the muscle. Stretch, hold. Make sense? So it's hold at this angle, whatever it is. I then stretch it and hold at this angle. This length, whatever. This is the firing rate, so I'm going to record from a type 2 afferent. So I'm going to put a little electrode on my type 2 afferent and see what it does when I stretch this person's hamstring. And this will be the firing rate, okay? So it's firing, going beep, 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 whatever, telling the body, the brain, you are at 3 inches of stretch, whatever it is. Okay? Then it'll do this. Okay? Contrast that firing pattern to the type 1A afferent. I'm recording from that little afferent as it comes away, and you'll see this firing pattern as you go through this ramp stretch. Okay? Well, let's add one more in. I'll now stretch the muscle faster. So this one, now rather than doing that, I'm going to go like this. You see what I mean? I've stretched it, I've gone from one angle to another angle, or one length to another length faster. Rather than going a slow stretch, I'm going to whip it through quickly and hold it. Now contrast. So that was the first 1A. Now I'm going to look at the 1A again, and it'll do this. You can see this. Does that make sense? So this one obviously corresponds to that there. This one corresponds to that. So what is the difference? What is the type 2 afferent telling the brain? What is the type 1 afferent telling the brain about this stretch? What do you think?
1A is the rate of stretch. And
Exactly.
2 is the stretch length.
The static length. So type 2 afferent gives us the amount of stretch, the static stretch. Okay? So the 1A afferent is sometimes called the dynamic afferent or the phasic afferent. So if you look at when it starts firing, so it's the background stimulation as 1A does. When it really goes crazy is when a person's actually going through the stretch. Once the stretch stops, it goes back to basically its resting level. And if you look at how fast you stretch, in other words, you stretch the muscle faster now, from this ramp to this ramp, you increase the firing rate of that thing, that 1A afferent. So the faster you stretch it, the more the 1A fires. As opposed to the type 2, is sometimes known as the static afferent or the tonic afferent. This does not care how fast I'm being stretched. It just cares how much I'm being stretched. So you can see on this, the type 2 afferent, as you stretch it, it gradually increases and then maintains that level of increased activity, telling the body you've now been stretched this far. Does that make sense? So in other words, again, the type 2 afferent continually tells the brain what the length of the muscle is, the amount of stretch. The type 1A afferent tells you how fast you're being stretched. The rate of stretch, not the amount, the rate, the change in stretch. Does that make sense so far? Okay? What do we... Okay, let's look at the functions, more the physiology, the function of this thing. Why have we got all this complicated mess? Well, perhaps the easiest ways to look at this is to say, how is a muscle spindle activated? In other words, how do I cause the 1A and type 2 to fire? What will make those fire? What will activate the muscle spindle? And I can think of broadly 3 ways you can cause that thing to fire. Passive stretch, obviously. Passive stretch. And we'll go over these in detail in a second. If you relax the extrafusal fibers, you will stretch the muscle spindle. Relaxation of extrafusal fibers. And I'll explain that in a minute. And lastly, contraction of the intrafusal fibers. Okay, so 3 ways. Passive stretch, relaxation of extrafusal fibers, and contraction of intrafusal fibers. All those 3 mechanisms can cause the muscle spindle to fire. Alright, let's look at passive stretch first then. Passive stretch. Okay, good example, muscle spindle. Muscle spindle with the patellar tap tendon reflex. Every time you passively stretch a muscle, it will activate the muscle. So what these, I haven't mentioned yet, but what these, I've got a picture of that. What these neurons do, they form a little reflex arc. I'll draw that. So the 1A and type 2 afferents, leaving the muscle spindle, go into which side of the cord? dorsal root, right? So here's my, let's draw the muscles, the patella reflex. Here's my muscle. Here is my patella. Here's my leg. Okay, there's my quads. And here's my patella tendon, there's my patella, right? Whatever. Alright? So here's my cord. Alright? Fair enough? 1A and type 2 afferents are going to come out of the quads, so any of the muscle, into the dorsal root, unipolar neurons of course, and they are, in this case, the muscle of the knee-jerk reflex. They do this. Okay? Simple as that. What does that what happens there then? What does the muscle spindle do when it's activated to the muscle it comes out of? What does it do? What's the effect of stretching the muscle spindle on the muscle that muscle spindle lies within? Traction. This is my alpha motor neuron. When I stretch a muscle, the signal goes in via the 1A and 2 into the back of the cord. It then synapses with my alpha motor neurons that are sitting in my ventral grey horn here. And lo and behold, that sends the signal to contract the quads. Every time you stretch a muscle, the muscle reflexively contracts against you. Okay? This is called the myotatic reflex. Not the inverse myotatic, the myotatic reflex. Remember, so the myotatic reflex. The myotatic reflex. Okay? Let's make it a little bit more realistic. Here is my antagonistic muscle, the hamstrings. Okay? So what we're looking at here is a knee-jerk reflex. I whack somebody's patella tendon with a hammer. Okay? And this is how the patella, or any stretch reflex works. You whack the patella tendon, patella ligament, what are you going to call it? Quadriceps tendon, whatever. What that does is tugs on the quads minutely. I pull a slight stretch on the quads. Within the quads are all these muscle spindles just sitting here. Okay? They detect that slight stretch. They don't like to be stretched. So they send a signal into the spinal cord, which synapses with alpha motor neurons, monosynaptic reflex in the case of the patella tendon tap reflex, monosynaptic, no interneuron in this case, many there are, that send a signal out the alpha motor neuron to contract the quads, and lo and behold, your knee extends. Okay? Same for your Achilles tendon tap reflex, your biceps, your brachioradial, all those reflexes you've done where you tap the muscle with a reflex hammer, right? What you're doing is stretching the muscle and provoking a contraction out of that muscle by that little stretch. Okay? That is a passive stretch of the muscle. That makes sense? Can you inhibit this reflex? The knee jerk? Can you? No. And what's the mechanism how you can facilitate it? What's that called? The Gendrasic maneuver. The OTs haven't heard of that one. The Gendrasic maneuver is where you deliberately try to stop, or at least you clench your fists, clench your teeth. You have the patient, just grit their teeth as hard as they can, and then you tap the tendon, and boing, it shoots up even more. Why is that? What is happening then? Why is clenching my teeth and grit, clenching my fist, gritting my teeth going to increase the level of that reflex? What's happening physiologically, neurophysiologically? You can try it sometime. What's going on?
Sympathetic response?
No.
Sending more signal down the cord.
Yeah. You're washing tons of facilitation down the cord. And what you're doing, these motor neuron pools here are facilitated. You're sending background stimulation into those, the overflow into those. So they're sitting there, ready to fire. So only a slight tap now will cause that to fire. Because they're close to threshold already. The ventral grey horn throughout the cord are hyper-facilitated because I'm psyching myself up. So a slight tap then will increase that knee-jerk reflex, the Janjasic maneuver. Never ever tell me, although I bet you 10% will on the exam, that the knee-jerk reflex is a result of the Golgi tendon organ. I'll say, explain how the tendon tap or knee-jerk reflex or the quadriceps tendon reflex works. And I go, tendon, Golgi tendon organ. I hit the patellar tendon. It stimulates the Golgi tendon organ, right? Of course, which then turns on the muscle. Complete rubbish. This has got nothing to do with the GTO. The GTO sitting in the tendon, yes. That's going to turn the muscle off under high force. This is you hit the tendon, but what you're actually doing is pulling on the muscle. The tug on the muscle causes the 1A afferent, type 2 afferent to fire into the muscle, into the ventral grey horn. Alpha motor neuron turns the muscle on. Let's make it more realistic. I cannot swing my knee upwards, I cannot extend my knee if my hamstrings are on. So we have to turn off the hamstrings. So this is what happens. Okay? So those 1A and type 2 afferents coming in send collateral side branches off to inhibitory interneurons, which then inhibit the alpha motor neurons going to the antagonistic muscles, whichever muscles you're looking at. This inhibition of the antagonists is known as reciprocal inhibition. Reciprocal inhibition is when you turn off the antagonistic muscle when you turn on the agonist muscle. Which bit? All of it? Okay, so when I activate the muscle spindle, the 1A afferents, the afferents come in. As they send the signal to the alpha motor neuron to go to the quads, side branches or collaterals go to this inhibitory interneuron here that inhibits the alpha motor neurons going to the antagonistic muscles of the quads, in this case hamstrings. So when I turn on my quads via the muscle spindle, via my alpha motor neurons, I also turn off my hamstrings. I could not have knee extension if my hamstrings were on. So I have to turn off the hamstrings. The process of turning the hamstrings off, turning off the antagonistic muscles, is called reciprocal inhibition. This is a very useful technique in physical therapy and stretching. If you activate the agonists, the antagonists are inhibited. For example, in patients with stroke, if you want to try to reduce the tone in a certain muscle, if you activate the antagonistic muscle of that one you're looking at, you will find a reduction in tone in the muscle you're trying, antagonistic to the muscle you're contracting. So when I contract my biceps, my triceps are automatically turned off. Reciprocal inhibition. Okay? This is a monosynaptic reflex. This knee-jerk reflex you cannot overcome. Many of these stretch reflexes you can overcome, and we've talked about one of these in motor control. We'll just briefly mention it here. Remember this word. I know OTs haven't seen it, so we'll go over it again. So what Nashda found here, so this, let's quickly work this experiment. The floor moved underneath a person's feet. Okay? When the floor moved underneath the person's feet, it stretched, it caused the ankle to dorsiflex. Okay? Which would cause the gastroc to contract, which would bring the person back up over their feet. He also looked at the bottom condition where the platform underneath their feet tilted upwards, which also stretches the gastroc. If I turn my gastroc on in that bottom situation, what would happen? I'd fall backwards. So the top situation is good, a good reflex to have. The bottom is a bad situation to have. And this will happen with practice. When the floor went backwards under their feet, electromyography, the signals coming from the muscles came on earlier and the sway reduced. On the bottom diagram, when the floor tilted up underneath your feet, you don't want the reflex to work, and so what happened, you can see the EMG, electromagnetic signals coming from the muscles, turned off, and the sway was reduced. So in other words, you can, with supraspinal control, big brain, you can turn the stretch reflex off in the gastrocs. Okay, you can turn it off. With higher center, the higher centers, the big old brain is continually modulating these reflexes, damping them down. Okay? But what happens when you get a lesion to the brain? What happens when you get cerebral palsy, you get a stroke, you get a spinal cord injury, you get a traumatic brain injury, whatever? This is what happens. If I lose my ability of the higher center to dampen or modulate my reflex centers in the spinal cord, the reflex centers go haywire. Okay? They have their life of their own. Some people will say the muscle spindle becomes facilitated. Other people will say it's the reflex or the alpha motor neuron pools within the cord get facilitated. They then cause more contraction. In other words, this little spinal, this reflex goes round and round and round and round. And that's what you get spasticity. That is spasticity. Spasticity is not the same as hypertonicity. Hypertonicity, remember, is just a rigid muscle. And it can come from many sources. Okay? You can get rigidity with Parkinson's disease. You can get rigidity with muscle contractures. You can get rigidity from burn patients who sit in a certain position all the time. Their muscles will get rigid. You hold a muscle in a certain situation, it'll get rigid. That's nothing to do with spasticity in itself. Spasticity is a very specific type of hypertonicity that's due to this reflex, this stretch reflex. And what spasticity is by definition is an increase in muscle tone proportional to the velocity with which you stretch your muscle. It's a non-linear increase in muscle tone as a result of velocity of stretch. In other words, I've got a spastic biceps. If I stretch it slowly, you can get little resistance. If I stretch it quickly, it will resist markedly against you. The faster you stretch a muscle, the greater the resistance is. Which afferent is responsible for that, do you think? Which afferent in the muscle spindle is causing that? The faster you stretch it, the more force you get against you. The 1A afferent. The 1A afferent is firing like crazy when you stretch a muscle fast. So a person with spastic muscles does not like to be stretched quickly. Bounce stretching, whatever, will not work. Okay? So the whole traditional approach to why spasticity arises is the loss of inhibition from the higher centers. The stretch reflex has a life of its own and causes spasticity. Okay? You don't see a spastic response in a patient with cobweb rigidity or a lead pipe rigidity. Lead pipe rigidity is where you get the same resistance however fast you stretch it. It's just the same gradual resistance against stretch. Spasticity is a very specific type of hypertonicity. And this was confused in the literature until fairly recently. They're used interchangeably, but they're not now. They will separate spasticity out from hypertonicity. Make sure you know the difference between them. There's definitely a physiological difference, a cause of these, and there will be a board's question on what is spasticity, how you treat it, why does it arise. And this is the most traditional way of explaining how spasticity arises, a loss of descending control over reflex centers. I'm not saying I agree with that, but that's the traditional approach. Okay? If you're talking about motor control, this might be a functional adaptation. People might deliberately do this to gain function. Okay, so that's basically how a muscle spindle reacts to passive stretch. Okay, so this is an example of passive stretch, a reflex hammer. I could passively stretch your hamstrings, same thing. I could reach out and touch my toes. I'm in effect just passively using gravity to stretch my hamstrings. As I stretch down, they will contract against me. If you want to get more stretch, theoretically, okay, I'm going to stretch my pecs. Which way will I get more stretch theoretically? Doing this, or like this? Or if I touch my toes, should I bounce up and down, or to go down and hold them? Theoretically, I'm not saying you have to do this, but which way will you get more stretch? Bounce stretching or a static held stretch?
Static.
And why? Well, think about it. If I do bounce stretching, as I go through that velocity of stretch, the diagram's gone now, but the 1A and the type 2 are going to fire, aren't they? The 1A is going to say you're stretching at this speed. And what does the 1A do? It turns the muscle on. What does the type 2 do? Turn the muscle on. But if I bounce down and now hold my hands on the floor, what happens to the 1A? It turns off. Because I'm no longer going through a velocity of stretch. So my 1A will turn off. And what is the 1A doing? Trying to turn my hamstrings on. So I will get less resistance, as it were, does that make sense, to my stretch if I hold the stretch. Does that make sense?
Is this called a passive?
Yes. Yeah. I'm passively stretching by bouncing, using gravity to stretch my hamstrings as I bounce up and down. Okay? Does that make sense? Now, they're doing experiments and often there's very little difference because people hate holding long stretches because it hurts so much. Whatever. But the fact is, when you use a velocity of stretch, a quick stretch, the spindle resists you more. That makes sense? Alright, let's get to the next way of contracting or activating the muscle spindle. The relaxation of the muscle extrafusal fibers. So we've got, this is the passive way. Basically, the muscle spindle gets stretched passively. Very similar, really, is the relaxation of the extrafusal fibers. So here's my arm holding a weight. And there's my biceps. Let's pretend. Okay, I'm holding my this 10-pound dumbbell curl, whatever, here, and there's my biceps in that state. Alright. I get tired or I stop paying attention. And my weight goes down a few degrees. Okay? The weight, in other words, I've relaxed my biceps muscle, my extrafusal fibers, and the weight sinks 10 degrees. When that happens, so the weight now goes down to here, 10 degrees at the end, the muscle spindles in my biceps detect that. They send a signal, of course, to the cord, which causes my biceps to fire and bring my elbow back up to the original resting length, whatever that length is. Okay? Fair enough. So I relax my muscle spindle, my extrafusal fibers, and then the biceps contract backwards to get back to the original 90 degrees. Okay. That is the situation. So that does not happen exactly. This is what happens. When the muscle spindles detect a stretch, they send into the cord saying, I've been stretched 10 degrees. I want you, therefore, to give me 10 degrees of activation to get back up to A. Let's call that A. Okay? So, in other words, my muscle spindle detects 10 degrees of stretch. They send a signal going back into the cord saying, you've been stretched 10 degrees, give me 10 degrees of activation, please, have the biceps to lift it up. Make sense? But, by the time, there's a delay in that system. You have to go through the cord, synaptic delay, etc., etc., etc. So, by the time the biceps gets a signal for 10 degrees of contraction, please, the arm is now at C, another 10 degrees lower. So I've now gone 20 degrees down. So this muscle has been stretched at this rate, 10 degrees per second, whatever. Okay? So, again, at level B, let's say, the muscle spindle detects a stretch. And it tells the body to give me 10 degrees of contraction. But by the time it gets to the back to the muscle, that feedback loop, you are now at C. So what would happen then? The muscle would go back up to B, wouldn't it? It would give you 10 degrees. It would go back to B. It's delayed. Does that make any sense? So, this is why we have a type 1A afferent. The 1A afferent says, when you're at B, you're being stretched at 10 degrees per second. You're being stretched at 30 degrees per second, or whatever it is. It tells the person, it tells the cord, the speed at which you're being stretched. And therefore, it allows you to predict the future. I know I'm going at this speed, and therefore, in a second of time, I'll be at whatever, level C. Does that make sense? So it can adjust the amount of contraction to get from C back up to A, because it knows how fast you're being stretched. So the 1A tells you how much to counteract that stretch with, because it knows how fast you're being stretched. The 1A doesn't. The type 2 doesn't. The type 2 just says, this is the static amount. Type 1A says, this is the speed of you being stretched. So you need to give me this much contraction out of the biceps to get back up to A. This is why we have the 1A afferent. It's predictive. It's velocity dependent. Does it make any sense? It's not a perfect system, though. It's not perfect. And so you do find, if you try to hold a weight perfectly still, even your hand perfectly still, you do see a tremor. It's about 10 hertz. There is a delay in this system that's trying to balance continually. You have a 10 hertz tremor slightly. That's the muscle spindle trying to balance, completely keep the person level. You see 10 hertz roughly, 10 cycles per second, this person, holding the weight. Does that make sense? So you've got passive stretch, you've got relaxation, extrafusal. This is a great reflex to have when I'm standing here falling asleep, getting bored of talking, and I'm fall forward, my gastrocs get stretched and they pull me back up. Or you're driving along the road, you're falling asleep. That's what's happening. It's a stretch reflex going, get your head back up. You're doing that constantly. because you're relaxing the extrafusal fibers in back of your neck muscles, and you get your stretch reflex and it pulls your head up. Okay? Last way, and probably the most complicated way to think about this is, okay, so far all we've talked about is the sensory portion of this. What the heck do we have gamma motor neurons for? Why have we got gamma motor neurons? Why do we have muscle fibers within this thing? Why not just have these receptors? Fine. Why have we got muscle in here? Okay, quite simple really. Why we have to have muscle within the muscle spindle. Right, here is two bones. Here is biceps muscle. Alongside of it, I'm going to draw the muscle spindle. Let's pretend that is the length of the muscle spindle. Of course that sits in there, but because it lies parallel to it, I've taken it out and stuck it here for you so you can see it. There's the muscle spindle, there's the biceps muscle. Fair enough? Okay, I am now going to stretch my biceps. So it's going to go from there to here. Passively or whatever. So what happens, let's say, when I go from A to B, the muscle spindle fires. I've stretched it, whatever this is, 4 inches, whatever, who cares? Perfect. Biceps holding weight, it gets stretched, muscle spindle fires, correct? That's what it's designed for. Piece of cake. And the arm will go back up, hopefully. Now I'm going to contract my muscle. Here's my biceps. I'm now going to contract it to this level. Okay? I've shortened it a long way. I've bent my elbow. What happens to the muscle spindle as I bend my elbow?
Contract.
Let's just pretend there's no muscle fibers in it for now, okay? There is my muscle spindle, right? Floppy. Because it's sitting in that muscle. If I shorten my biceps, the muscle spindles sitting in the biceps get all floppy. They can't help it. So then, this is level whatever C, who cares? I'm now going to stretch it. I'm holding its arm here now. And I'm going to stretch it, not to A, but to this level, whatever this level is, we'll call it C something. Does that make sense? This is the original level of the muscle. I've contracted, I've shortened it, so it's now this length. From that length, I now stretch it. But not back to here. I stretch it halfway, let's say. What happens to the muscle spindle then? Will it fire? No, because it's still floppy. It's not as floppy as this, but it's nowhere near this length. That makes sense? So in other words, this muscle spindle is worthless to me at any length shorter than A. Does that make sense? This muscle spindle could not detect stretch if that's all it was. It only had a passive component to it. So this is why we have gamma motor neurons. Because when we contract my biceps, the extrafusal fibers, I contract my intrafusal fibers too. So when I shrink the biceps down from A to what it was C, I also contract my muscle spindle using my gamma motor neurons. So when I go from C to D, what happens to my muscle spindle? It fires. isn't it? Because I shortened it at the same rate as I shortened my biceps. So in other words, the gamma motor neurons and the intrafusal fibers keep the muscle spindle at the same length as the extrafusal fibers. So at any range of motion, any length, the muscle spindle is capable of detecting stretch. Does that make sense? This is, if you read those PDF files I put in your folder, they'll explain it way better than I did. So a gamma motor neurons, you have to have the ability to contract your muscle spindle at the same time as you contract your biceps or quads or whatever it is, or else it's worthless. Does that make sense? Because it lies within the muscle. Okay? So you find muscle spindles you find much more prominent in where you want fine control of muscle action. So in very fine controlled muscles, you find a greater ratio of muscle spindles. So where do you think, what muscles do you think you find a lot of muscle spindles in then? What the?
Yes.
Hands, and what's even better, more important? Erica? Eyes. You've been scratching your eyes. Yeah. The eyeball muscles, all the extra, you've got to control your eyeball muscles very, very carefully. Massive amount of muscle spindles. You also find a lot in postural muscles that allow you, for example, my soleus is packed with them because it wants to maintain me over my feet all day long. I want to balance. Okay? So, this is what's known when you activate the gamma and the alpha at the same time. This is called alpha-gamma coactivation. So in other words, or sometimes called alpha-gamma linkage. This is what's not always thought to be the case. The original concept, and it's not entirely accurate, but we mention it because it shows something important. Merton's follow-up servo mechanism. This is the way people originally thought you contracted your butt muscles. And the reason why I thought this was because when you stimulate the brain electrically, manually, artificially, so you zap somebody's motor cortex, right, during surgery, and you record from the gamma motor neurons and the alpha motor neurons at the same time, you'll find the signal comes down the gamma first, and then the alpha second. So what Merton thought, he proposed this follow-up servo mechanism. Maybe it works on very slow, well, let's get to that in a second. What's a servo mechanism? What's servo assist on your car? What? Power steering, right? Power steering, power brakes is a servo mechanism. A servo mechanism where you put a little bit of force in to get a lot of force at the other end. You turn your car engine off, right? Your brakes, you have to press like crazy to get your brakes to work. Without the servo system, you have to push much harder. But what a servo system is, where a little bit of force controls a motor over here or something, makes a lot of force over here. So the way he believed people control muscle is, I want to bend my arm from here to here. So what you do, according to this mechanism, you send a signal down the gamma motor neurons to shrink the muscle spindle. Then what happens when the muscle spindle detects the stretch? It sends a signal back into the cord to contract the extrafusal fibers. So in other words, you set your muscle spindles at this length, and the biceps follows up and goes to that length. Does that make sense? You control your extrafusal fibers by contracting the intrafusal fibers first, and the rest of the muscle follows up to that length because the muscle spindles get stretched. That makes sense? But there's a delay in that system. You don't send a signal down to the gamma first, and then the alpha follows back up. It's this alpha-gamma coactivation now, they think. Because when you send a signal by yourself from your brain, not artificially like they did, if you initiate movement by your motor cortex, you find alpha and gamma fire at the same time. Alpha-gamma linkage. So you shrink the muscle spindle at the same rate and length as you shrink the big muscle. Does that make sense? This is a very important reflex to understand. The muscle spindle is very important in understanding spasticity, understanding many treatment approaches of your neurologically involved patients. And there's lots of questions on this kind of stuff. If you don't understand that level of detail, you might miss things. So let's look at this last thing we'll stop. Spasticity, this amount of spasticity, this is caused by muscle spindle, right? Caused by loss of control from the higher centers. So how would you treat spasticity then? What are techniques you've been using to treat spasticity? Remember, the old days, well, a lot of your therapists might still believe this, you should never provide electrical stimulation to a spastic muscle, should you? Never ever give E-stim to a spastic muscle. Never ever strengthen a spastic muscle. That's the NDT or Bobat approach. And most therapists will probably still believe that. You should never increase the force, never stress a spastic muscle, because it will get more spastic. Okay? Which is complete rubbish. A spastic muscle is a weak muscle. Okay? And if research has shown if you strengthen a spastic muscle or you give E-stim to a spastic muscle, you will regain more function and you'll actually sometimes reduce the spasticity. Okay? But that, I would say 80% of the places you go out in your clinical affiliations will say that was blasphemous. You should not strengthen a spastic muscle because it will make it worse. Or you should not give E-stim to a spastic muscle because it will make it worse, because of the stretch reflex issue. Other things you'll see done is they'll try and kill the muscle, right? This is abnormal tone is bad in the gastrocs, in the hamstrings of this patient. So we'll kill it. So what you do to kill it? You Botox the heck out of it. Botox a muscle. It kills the neuromuscular end plate, the neuromuscular junction. It kills the motor end plate for a while. They grow back, but you're trying to reduce the tone by squirting the kid with Botox. Or in even severe cases, what will they use? Another drug. Baclofen. You've heard of that one, yeah? Baclofen. They'll drip baclofen into the kid's spinal cord using an intrathecal pump. They'll titrate it very carefully. If you give them too much, they're a completely floppy bag of jelly, worthless. Don't give them enough, they've still got this hypertonicity. So baclofen is another common technique trying to reduce the overall tone, this infusion pump, into the kid's legs. And we talk about motor control in spastic diplegia, remember? Those kids who walk on their tiptoes, they'll try to lengthen their tendons. And orthopedic surgeon will cut the tendon with a Z-cut to lengthen it, like an accordion, to allow the person's heel to get on the ground. Or they'll stretch the heck out of it, serial casting. None of these techniques particularly work very well, but strengthening usually does, helping out. Because these kids, remember, have developed this spasticity, if you want to call it that, as a functional adaptation. When they're born, they realize, not consciously whatever, that I can't get around the world with two floppy bags of jelly in my gastrocs that I cannot control because of my CP. So what they do is they produce two pogo sticks in the legs and they bounce off these pogo sticks. Thank you very much, very well. It's not the perfect gait, obviously, but it's better than having two muscles I have no control over. If you make two stiff springs, I can use these to walk around and bounce off them. And your surgeon comes in and cuts the muscle, kills the muscle, it takes away the one thing the kid had to get around. So that's a different way of looking at spasticity. I'm not getting into that motor control, but there are various treatments for spasticity. You must be aware of this, right? Pharmacological, therapeutic, And you'll all see it out there. You'll all see spasticity. But remember, this is the traditional approach of why it occurs. It's a stretch reflex generated by the muscle spindle that is hyperfacilitated. And remember the difference between spasticity and hypertonicity. You've got to partition out spasticity and hypertonicity. Spasticity is a result of a stretch reflex, and it's the faster you stretch a muscle, the more you get resistance against you. Also, another thing I saw talk about, and we'll stop. Dorsal rhizotomy. They'll cut dorsal roots of young children, don't they? Sometimes they'll go in and they'll snip those dorsal roots going into the kid's cord. So they'll cut these green lines here. They'll cut the dorsal roots. It's called a selective dorsal rhizotomy. Have you heard that term? I have a PTO. Yes, OT has heard of rhizotomy? What they'll do is they'll stimulate those little green fibers. So here's a better picture perhaps. So they stimulate these little rootlets going in, those posterior rootlets. And they'll see how much contraction you get out of the muscle. If it's too much and inappropriate, they'll snip it. Then go to the next one, go to the next one, snip that one, not that one, not one, snip that one. So they reduce the amount of 1A and type 2 afferent coming into the cord. And therefore they're reducing the alpha motor neuron output, try to reduce the spasticity in that child's legs. Okay, is that a lot today? Read those PDF files slowly. There's not much in the book, but there's a lot on those files on your first class account on proprioception and muscle spindle. We'll carry on talking about reflexes in the core next class.